The 3 cycles of
so 3 cycles of various regimes are given. Which regime is used for commonly used in locally advanced breast cancer?
So CAF based regime is used, which
adriamycin based regime.
Yes,
CAF is a regime itself. Adriamycin based regime or epiribicin based regime can be used. Cyclophosphamide, adriamycin and 5-FU. What are the side effects of adriamycin?
So adriamycin is basically cardiotoxic.
So what investigation would be required before we start the neoadjuvant
ECG
chemotherapy?
and echo of the patient.
No, whole thing. What investigation would be required?
So ECG and echocardio, the baseline cardiac.
You require. I mean, the question was what investigation would be required before we put the patient on neoadjuvant chemotherapy? Blood counts, platelet counts, and also ECG and echo. Right?
Yes.
Now we're moving on. So we'll put the patient on neoadjuvant chemotherapy, CAF regime, 3 cycles at 3 weekly interval. Why 3 weekly interval, Shaili? Why should we divide it?
We give time to the normal body cells to recover.
Okay, normal body cells and also the bone marrow to recover.
Also the bone marrow.
Bone marrow primarily. Now, why do you do platelet counts? Shanice?
So it's to test for the red marrow.
Red marrow. And therefore, we need to test for the red as well as the white marrow. We do the total, that is the TLC as you call it, and also the platelet count so that we are able to assess both. Now, we have, subsequently, if the patient is a responder, as Dr. Megha was mentioning, patient would have more than 50% reduction in tumor size, and if there are micrometastases, they can be taken care of. And if the patient is a good responder, we proceed with 3 cycles and we subject the patient to surgery after 3 weekly interval, after the gap of 3 weeks from the last cycle. And finally, we actually have patients subjected to modified radical mastectomy. The discussion of modified radical mastectomy is slightly beyond the scope of this case presentation, but this is an aspect that must be discussed. How about adjuvant chemotherapy or adjuvant therapy in these patients?
So we would like to put patients on adjuvant chemotherapy if they are good responder initially with new adjuvant chemotherapy. So otherwise we have to give them second line of
But we have to give adjuvant
yes,
chemotherapy. Sir. What else? What other adjuvant therapy you would give, Dr. Siddharth?
So apart from chemo and radiotherapy, hormone therapies are
radiotherapy. When do you give radiotherapy? All patients with locally advanced breast cancer, patients with margins being positive, patients with poor grade, patients with angiogenesis, patients with lymphovascular invasion, and more than 4 lymph nodes in the axilla positive. If provided, 10 have been removed. Optimum axillary dissection during modified radical mastectomy is removal of 10 nodes. Modified radical mastectomy means removal of the breast along with nipple areola complex, along with axillary tail of Spence, pectoral fascia, and all the 3 levels of lymph nodes. Level 1 is lateral to pectoralis minor, level 2 is behind pectoralis minor, level 3 is medial to the medial border of pectoralis minor. All 3 levels are removed. Lateral limit of axillary dissection is thoracodorsal pedicle and Letzmer's dorsi muscle, and medial limit is Halstead ligament, upper limit is axillary vein, lower limit is angular vein. This is the axillary dissection that we'll do, and we'll subject the patient to radiotherapy subsequently depending upon the observations or the findings of histopathology. So we'll subject these patients to neoadjuvant chemotherapy followed by surgery followed by adjuvant therapy, which could be in the form of chemotherapy, radiotherapy, and as Siddharth was mentioning, hormone therapy. Which group of patients would require hormone therapy?
So if a histopathological sample establish a estrogen progesterone
immunohistochemical sample. Histopathology is the pathological diagnosis. Immunohistochemistry shows it to be ER/PR positive tumor. No ER/PR negative patient is put on hormone therapy. What hormone therapy?
Tamoxifen, selective estrogen receptor modulators.
That's right. We can add aromatase inhibitors in some patients after giving 5 years of tamoxifen 20 mg OD. The side effects of tamoxifen. What are the side effects of tamoxifen, Siddharth? Siddharth, what are the side effects of tamoxifen?
Usually cardiovascular side effects as well as osteoporosis may set in early in the female. Together with increased incidence of uterine cancer.
Endometrial hyperplasia leading to endometrial cancer. Now, this was in nutshell about locally advanced breast carcinoma of 2 female patients. We have a case of male CA breast also, which would be which could be a similar scenario. And we're going to discuss this case. To discuss this case, we have Dr. Rohan Khandelwal to present the case, please.
Thank you, sir. Good evening, everyone. I'm going to present a case of locally advanced breast cancer in a male. A 50-year-old gentleman, a farmer by occupation, resident of a village in Uttar Pradesh, presented to our hospital with complaints of an ulcer over the breast for the last 3 months. and multiple swellings in the left axilla for the last 2 months. The patient was apparently well 5 months back when he noticed a rapid increase in size of his left breast, followed by a small ulceration over the left breast, which rapidly increased in size and failed to heal despite local remedies. The patient also gave a history that it bled on touch. The patient also complained of pain on moving the left arm. History of weight loss was present. There was no history of nipple discharge. The metastatic history was negative. There was no significant past history, no history of radiation exposure, no history of infertility or testicular disease. Family history was non-contributory, and the patient wasn't addicted to any form of tobacco or alcohol. That's the history. An examination, the vitals of the patient were stable. The Karnofsky score was 90%. His nutritional status was poor, as he had pallor was present. His hydration status was adequate. The local examination revealed a grossly enlarged left breast, with the lower margin of the left breast being lower than the right breast. On examination, the right breast appeared normal. The left breast was grossly enlarged, and an ulcer was seen involving the nipple areola complex, measuring 5 centimeters in diameter. The edges were at some places the edges were sloping, where other places they were punched out, and there was bleeding from the margins. The floor was covered with necrotic tissue, and areas of hemorrhage were seen. The base was formed by the underlying structures. On palpation, an evident underlying lump was also felt, which measured 10 into 8 centimeters. Was hard, non-tender, and fixed to the underlying muscle and the chest wall. There was a fullness in the axilla seen. On palpation, there were 2 lymph node masses measuring 4 into 3 centimeters, fixed, hard, non-tender. The axilla on the other side and the supraclavicular fossa were normal. The systemic examination was essentially normal. This is a close-up view showing the necrotic region and the floor of the ulcer. Systemic examination was normal. That's my case.
So what's your case?
It's a case of a 58-year-old male patient with locally advanced breast carcinoma, stage T4C, N2, M0.
This is more like T4C. Any questions from the audience? Anything you would like to know about the case? You can ask straight away. Pass the mic to him.
Anything different we would do if it's a male breast carcinoma locally advanced?
Well, that is the key reason for presenting this case. As far as the breast cancer is present, whether it's in the male or a female, the treatment is based on the stage for stage, and as you compare an apple to an apple, the treatment is the same. The treatment for breast cancer in males and females is the same. Yes, but the point is, at presentation, male breast cancer is usually more advanced. It is gone because it's closer to the chest wall. Therefore, chest wall is more likely to be involved here. But involvement of chest wall in a female patient takes a little while longer because of the fat. But otherwise, it's the same thing. Now, if I may ask you, what can increase the chances? What previous history would be of relevance? You said no history of radiation. That's very valid. Anything else that increases the chances in a male patient?
So if the patient is a case of Klinefelter syndrome, in those cases the patient has gynecomastia, which can later turn into malignancy as well.
What is Klinefelter?
Klinefelter syndrome is a genetic syndrome in which the XXY is
trisomy.
Trisomy.
Right. Now, actually, the gynecomastia per se is not a high risk factor. It's not a precancerous condition, which is often a question asked. But in patients with Klinefelter syndrome, if there is a gynecomastia, it's likely to be. One has to suspect it. And the other thing is gynecomastia. If it is bilaterally present, if it is present on both sides, it's likely to be either hormonal or due to systemic conditions. What systemic conditions can produce gynecomastia?
So cirrhosis,
liver disorders, and drugs that damage the liver. Anything else that can produce gynecomastia?
So even estrogen.
Yes, intake of estrogen. Any idea where it was used or where it is used?
So prostatic cancer.
Yes. So in those conditions, you may actually get a gynecomastia, and gynecomastia due to a systemic disease is not. You can get gynecomastia even in alcoholic patients. It is one of the stigmas of liver disease. So you must suspect it in a patient. I mean, if it is bilateral, it's more likely to be systemic due to a systemic reason. But unilateral gynecomastia is likely to be more dicey. Now, presentation is about of a locally advanced breast cancer. The approach should be similar, or would it be any different, Dr. Rohan?
So it's the same as.
So what will you do quickly?
So triple assessment. The clinical examination has already been covered, followed by imaging modality to see the other.
What
breast.
imaging modality?
So in this case, an MRI would be ideal to look for.
No, what could be a poor man's MRI?
See, ultrasound can be done.
Okay, so you can do an ultrasound. MRI would be expensive for every place. Okay, why not a mammography?
So because the other side there's no breast tissue. So
it's difficult to do actually. So there is a technical problem relating to it. Therefore, you will go for ultrasound or MRI. Anything else you would like to do?
So followed by a core biopsy of the patient.
What is your thought on FNAC?
So FNAC,
Done, not done?
so it can be done, but it will not tell us about the ERPR, immunohistochemical status of the patient. So later on,
it will not tell you about the grade also. Grade also. Now, how do you manage him?
So we'll put the patient on neoadjuvant chemotherapy.
What regime? For how long?
So CAF regime, 3 cycles. We'll assess the response after 3 cycles at 3 weekly intervals. If the patient is a responder, or after 3 cycles, we'll subject him to modified radical mastectomy, which in this case we would also like to resect the part of the chest wall which is involved, and followed by adjuvant chemotherapy and radiotherapy in this patient because it is involving the chest wall, and hormonal therapy.
How old is your patient?
58 years.
Yes, it doesn't look 58. If he was 78, what would you do?
So then subjecting him to chemotherapy and also hormonal therapy. Surgery would be too taxing for that patient.
I thought chemotherapy is more taxing, and as a surgeon you should believe it, because chemotherapy is very toxic, and therefore I was actually going to discuss for all the 3 cases of locally advanced breast carcinoma what would be the contraindication to putting the patient on chemotherapy or radiotherapy. Very poor performance status, right? Old patients, more than 80 years of age, and with radiotherapy is contraindicated in which group of patients?
So those which have received radiotherapy in the past.
One is those who got radiotherapy in the past, yes. Any disorders which?
Collagen vascular disorders.
Now, so you can't give it there, so therefore you would like to avoid it. Now, treatment is very clear, but he mentioned about chest wall resection, so I'll quickly sum it up. You can't resect the whole of chest wall. Up to 2 ribs can be actually taken up comfortably, and therefore chest wall resection in a space of about 4 centimeters is okay, but we'll make sure if we can, because in males it's difficult to ascertain it, but you'll do investigations by when you're doing MRI, you'll know whether chest wall is involved or not. If it is not involved, we'll shave off the tumor. And how about the hormone therapy in these patients?
So if the tumor is ERPR positive, we subject him to hormone therapy, which is the same as in females.
If it is HER2 positive,
we can give Herceptin.
What is Herceptin?
Which is a monoclonal antibody against HER2
targeted therapy. How many cycles?
That I'm not aware.
Okay, how many? It could be about 8 to 10 cycles, and it turns out to be an expensive therapy, but one can attempt it and give it. So by and large, standard protocol, neoadjuvant chemotherapy followed by surgery, followed by adjuvant therapy, with the same chemotherapy if the patient is a responder, or with a different chemotherapy if the patient is not a responder. Second line chemotherapy. Dr. Megha, what will be the second line chemotherapy in patients with breast cancer that are not responding? Taxane based chemotherapy, and any other, what can you name any taxane based chemotherapy? You can sit down. Paclitaxel. What is there any other therapy available which you can add on? Well, you can, second line chemotherapy would include paclitaxel. I was going to ask a question from Siddharth regarding his patient, because she was premenopausal. She was premenopausal. What would be the other option if she is PR positive?
So the hormone therapy.
What kind of hormone therapy you can give?
So patient could be started on tamoxifen.
What's the role of oophorectomy? That's what I was interested in asking. Oophorectomy can be offered as a second or third line therapy, but tamoxifen is preferred in even in premenopausal patients. Now we move on to the third case, so that since there is a limited time, which will be a slightly different scenario, and this case would be presented by Dr. Nikhil Narayan, who is going to be presenting a case with a lump in the breast, which is not exactly the classical breast carcinoma that you encounter. It's over to Nikhil now.
So my case is a young female of 20 years old age.
You can make
So
it into a slideshow.
Yes.
Okay, you can carry on with the history. Yeah.
So she is a resident of a neighboring area from Delhi, and so she has presented with a lump in the
Change the
right
slide.
breast.
Move to the next one. No?
Lump in the right breast.
To the slide, so that we have the history.
Yes, sir. So she presented.
You carry
with
on.
a,
You'll change the slideshow. Okay.
lump in the right breast since the last 5 months, and so the lump was insidious in onset, fast progressing. There was no history of the pain, so but it was associated with ulceration in the dependent area of the right breast for about 15 days, and also foul smelling discharge from the ulcerated area, which was around 200 ml every day. And so there was no significant weight loss, not a known case of tuberculosis or diabetes, and there was no history of familial malignancies of the breast, ovaries, or colorectal. So the patient is not married, and she is menstruating normally. So on general examination, she is Karnowski 19. There was a significant pallor in the patient, and so the vitals and the systemic examinations, it was within
normal limits.
normal limit. So coming to the local examination,
Right.
so on cross inspection, the left breast.
Left breast is normal. The
yes, sir.
findings of the right breast, you
Yes,
can tell us. Okay.
So the right breast is massively enlarged,
Right.
reaching up to the umbilicus, with a lobulated appearance.
Right.
Nipple areola, the complex could not be visualized because of the ulceration,
Right.
and the skin over the breast is red, engorged, stretched, and so there is ulceration along with foul smelling discharge.
Okay.
So the arm, thorax,
Everything
axilla.
else was normal.
Yes, sir.
Can we see the picture of the case?
Yes, sir.
Right. Why did they change the thing? They should keep the slideshow on. Okay.
Yes, sir.
Where is the? Can you point to the
Yes.
lump? Okay.
So this is the lump showing the right breast, and so the surface was lobulated. I'm sorry, I could not expose the patient completely.
Okay.
So it was massively enlarged,
Okay.
and so this area is showing the ulceration, where there was foul smelling discharge from.
Okay. Fine. Let's move on. So what was your?
And-
Is that your case?
Yes,
Can you summarize it?
yes,
quickly?
yes. So it is a 20-year-old young female presenting with a massive lump in the right breast, along with features of inflammations, and there is no nodes.
Was the skin free,
palpable.
or you thought skin was involved?
Sir, it was not involved, and a probe test.
What is probe test? It's a very good point.
Yes, sir.
What is probe test?
Sir, a probe could be inserted in between the skin and the tumor.
Okay, so that makes your case a very. I mean, probe test would be diagnostic for a particular scenario. What
Yes,
would
sir.
that be?
Sir, it is actually diagnostic for cystosarcoma phalloides.
Is the lymph node? Are the axillary lymph nodes involved?
No, sir.
There were no axillary lymph nodes.
No, sir.
What is phylloids tumor?
Sir, the phalloides tumor is a tumor of the breast, most often benign, sometimes malignant, which diagnosis is mainly clinically and pathological.
Mostly pathological and clinical. I think I agree with you. Now we have a similar case that Dr. Kamran is going to present. So what we'll do is we'll have both the cases and then we'll discuss about their profile. So Dr. Kamran Ali Khan to present the case. He's a postgraduate student at Southern Hospital. Kamran, can we have your case quickly, please?
This is a photograph of the lady, a 35-year-old female. She presented to us with a large breast lump for the duration of gradually progressed to reach the present size.
Please.
This is the one, sir.
Okay.
So there were no features of inflammation like pain, redness, fever, and there was no lump on the opposite side of the breast. There were no systemic features. So the past history, family history and personal history were all within normal limits.
So let's look at the local examination.
Yes, on examination we can see that the right breast was normal, the left breast was massively enlarged, almost the whole of the breast was replaced by the lump. It was 25 centimeters by 18 centimeters in size, surface was bosselated, the consistency was variable, cystic at certain points and firm at other points. The nipple and the areola complex were normal, although it was displaced outwards and downwards. There were prominent veins overlying the skin, but no other skin changes like redness, ulceration, satellite nodules, no excoriation of the nipple and the areola. And in this, there was the axillary lymph nodes of the same side which were present, about 3 centimeter by 3 centimeter in size. They were soft and freely mobile.
Okay. Now, so what's your case? Similar to the case that Nikhil presented, or it's any different?
So it is the same case, a case of Phyllodes tumor of the left breast in a 35-year-old.
Similar case, can't be the same case.
Yes, sir.
So it's a similar case with a different presentation, similar presentation, okay. What do you find?
So a large lump which is free from the skin, free from the underlying structures, no evidence of any skin changes,
Okay,
which is variable in consistency.
right. So what's your diagnosis in this case?
So a 35-year-old female with a Phyllodes tumor on the left breast.
That's very good. Actually, that's a short case, and that's therefore we skipped most of the detailed history. Now the question is directed at both of you. What is a phyllodes tumor? Both of you can answer. Anyone can take it.
So Phyllodes tumor is a large tumor of the breast,
Right.
which presents with a bosselated surface and cystic cavities.
Okay.
And on histopathology, on the cut surface, there is a typical fern leaf pattern, and it is
Fern
usually
leaf
benign.
pattern. Okay.
Yes, sir.
All right. What makes it a misnomer, Shally?
Neither it's cystic nor it's a sarcoma.
So what is it?
So it's
The term is cystosarcoma phylloides. He's right, because you tend to get a feeling that it's cystic with a sarcomatous character, which is both of them are not right. So what is right about it that is not mentioned?
So it can undergo sarcomatous change.
Well, so there is at least some partial truth in it.
Yes, yeah.
Now, what is the characteristic of this? Dr. Kamran, would you like to take that?
So
What
it
is what is the characteristic of cystosarcoma phylloides?
So it is due to the histopathology under the microscope we can see that there is proliferation of the stromal elements. There is increased cellularity.
Yes.
There may be certain nuclear pleomorphism and mitotic changes.
Yes.
And
What is it that you will require before you make a diagnosis? Would you require a mammography in this case?
not in this case.
Is there any problem if you do it?
We do not need a mammography. We are thinking of a benign lump.
Okay. Why do you think it's a benign lump?
So it has been there for the last 5 years. It is gradually
So
increasing in
points in
size.
history?
Yes, sir.
The answer would come like this: points in history, long history.
Yes,
Okay.
sir. So it is a large tumor,
Right.
and there is no skin changes, no involvement of the skin,
Right.
and the patient does not give any history of loss of weight, loss of appetite. It is freely mobile. It's not
Okay.
fixed to the underlying
Now, but
structures.
does that rule out any malignant change in a swelling which has been there for so long?
No, sir.
So now it doesn't rule out what you said initially.
Yes.
Now, when would you suspect that it is changing into malignancy?
So rapid increase in size, involvement of the lymph nodes,
Right.
and sir systemic features.
Can you find lymph nodes normally also in phyllodes tumor?
Yes, sir.
In what percentage of patients you get lymph nodes?
So around 20% of the patients we get lymph nodes.
And what percentage of these are actually malignant, metastatic lymph nodes?
Only 5%, sir.
So what is the cause for these lymph nodes?
So it is due to infection in the central part of the tumor due to necrosis.
And why is there necrosis?
So because of the large size, the blood supply cannot keep pace with the increasing size of the tumor.
Well, there's something about keeping pace. There's no blood supply to the center like most tumors which grow to this size. Anything else that makes you think it is not malignant? But phylloids can change into malignancy. There are various types, no?
Yes,
You
sir.
have- what are those? The high risk, low risk, intermediate risk.
Yes, sir.
So how do you make a diagnosis of phylloids?
So the diagnosis is essentially histopathological,
Yes.
although there can be clinical suspicion.
Clinical suspicion, but a diagnosis would be histopathological. What would you do in histopathology? You'll do a true cut biopsy.
Yes, sir.
Right? In this patient, where would you do the true cut biopsy from?
So from the firm part of the lump.
Right, and if you can do some imaging along with it, wouldn't that make your biopsy more representative?